Hi, guys. I'm Sophia. I am a nurse practitioner at CHLA. Angela made this presentation with me, couldn't make it today, but shout out to her. So as you guys can see, there's a ton of people involved in getting CAR T cell therapy. I'm going to be specifically talking about patients who get CAR T cells and how do we manage them in the outpatient setting. Clearly, it's very multidisciplinary. There's a ton of people involved. There's a lot of logistics for the families to come to the hospital as frequently as they need to if they're going to be managed outpatient. So I want to talk about the role of the outpatient nurse or the APP, knowing and understanding the process and timeline of CAR T cell therapy, understanding the short-term and long-term complications, and then how and when to monitor for those, and how do we prevent them from happening in the first place. So this is an overall of the whole process. Everyone went into certain parts and details of this, but overall we see them at the initial stage when they come in before their collection and they have to get consented for that. They get an apheresis catheter, we remove the blood, they are shipped and processed, and then they come back a couple of weeks later and we see them again before they get their chemotherapy and their cell infusion and then monitoring. So first, what we do is we always get a bone marrow and a lumbar puncture so we know what their disease status is. Super important so we understand their risk for complications. The higher their disease burden, the higher the risk for CRS and ICANS. And then we always do a temporary line if they're just getting an apheresis for collection. They come back, they get their updated H&P, see if there's been any changes in their clinical status since we saw them for their collection. They get another bone marrow and lumbar puncture so we can see again what their disease status is. They get a line placed. We always want central access just in case they have any sort of complications, even though they're outpatient. And then they come in for lymphodepleting chemotherapy. We typically give fludarabine and cyclophosphamide for 4 days. They get cyclophosphamide and fludarabine for the first 2 days, and then just fludarabine for the final 2 days of the 4 days. They get 1 or 2 days of rest, and then they come in for their cell infusion. Also, typically, the chemotherapy is really well tolerated. As a nurse, you're always looking for any sort of side effects, nausea, vomiting, making sure they're hydrated. And here are things that we always need to keep in mind. So we expect the CAR T cells to expand in their body roughly 7 to 10 days after they get their infusion. So that's when they're at the highest risk for any sort of complications. We bring them in 2 to 3 days a week for the first month. So for the first 2 weeks at our institution, we see them 3 days a week. And that's sort of for within that 7 to 10 day window. And then after that, we see them twice a week. During our visits, what we're doing is we're measuring if they have any sort of fevers, changes in vitals, changes in mental status. We check their labs. We see if they're at risk for any infections, any electrolyte abnormalities, any signs of CRS, any inflammatory markers. And then what a TBNK is basically we check all their T cells and also their B cells and see if there's an absence of their B cells. If they have an absence of B cells, it means that the CAR T cells are in there killing them, doing what we want them to do. And then we typically do a disease evaluation once a month after they get their CAR T cells. So their first one is 1 month out, we do a bone marrow and a lumbar puncture once a month for the first 3 months. And we bring them in monthly for the first year. And these are ways that we prevent complications from happening in the first place. To prevent any sort of seizures, we give them Keppra. We actually start at the start of chemotherapy and continue it for the first month after they get the CAR T cell infusion. We continue it for longer if they have a history of CNS disease. The reason being, if you have a higher disease burden in your central nervous system, if the CAR T cells go and kill it, you probably release more inflammatory markers and are at higher risk for seizures and neurotoxicity. And then antibacterial prophylaxis, we're always checking their labs, specifically their neutrophils. If they have an ANC less than 500, they're at a high risk for bacterial infections. So we start them on levofloxacin typically to prevent any sort of bacterial infections from happening. We keep them on antiviral prophylaxis for the first year. The reason being, if you don't have any B cells, you're at high risk for viral infections. So at our institution, we use acyclovir, and then we give antifungal prophylaxis for the first 30 days, and that's until their bodies recover from the chemotherapy. We also give them Bactrim or pentamidine for PJP prophylaxis, and then because the CAR T cells kill the B cells, their bodies are unable to produce IgG, which protects them again from viral infections. So we supplement them with IVIG monthly for as long as their B cells are absent. And then cytokine release syndrome, I know you guys had to talk about this, so I'm not going to go too in depth on it, but basically what it is, it's when your body releases inflammatory markers, and it's a good thing kind of with CAR T cell therapy because it means they're going in, killing the cancer cells like we want them to, but there's a very careful balance so that we can keep our patients safe. The higher the disease burden, the higher the risk for CRS. There was actually a talk at the ASH annual meeting, and it showed that 56 to 70% of patients actually had CRS to some degree after CAR T cell therapy. So here are some signs and symptoms of CRS. As the nurse, you're the eyes, the ears, and also the educator outpatient. So really what one major part of your job is educating the family so they can recognize these things if they happen at home, because they're really only coming into clinic for a quick visit. Fever, headache, low oxygen, rash, tachycardia, hypotension. You guys can read that, but these are some examples. Another thing is, here's a grading and kind of what we do. Here's the grade. Severe reaction, basically outpatient. If they have any grade of CRS, they're going to be admitted and go inpatient. So it's really just monitoring them, and we typically send them to the emergency room if they show any signs. And then CAR T-related neurotoxicity, also called ICANS, which stands for immune effector cell-associated neurotoxicity syndrome. It's a mouthful. The mechanism's a little bit unknown, but essentially it's inflammation in your central nervous system. It typically peaks 3 to 10 days, which is why we also watch them so carefully for that first week. And the one thing I always tell families is if they feel like they're even just off and they can't even really explain what's wrong, maybe they're responding a little bit slower, slurring their words, it can be pretty minor to pretty severe. And these are some symptoms of that. And then there's grading scales as well. There's 2 different kinds. One is our ICE scale, and that's for patients that are greater to or equal to 12 years old. And then our CAP-D scores, which are for patients that are less than 12. And this is what the ICANS grading score looks like. You basically ask the patient to do a couple different tasks. And then this is what the CAP-D score looks like. It's a little bit more like the FACES scale, where you're seeing how they respond and judging based off of that. And then other things to think about are central line. If they have a central line, they're at risk for infection. They need to have supplies. They need to have appropriate teaching. Nutrition, we always do a consult with our dietitian. We always have emotional and mental health support, and then other services like transportation and housing, because if they're getting this outpatient, we require them to be within 30 minutes to an hour of the hospital for the first month. So for a lot of people, they need housing, transportation, and monetary support. And then here's just a little scenario. Tyler's a 6-year-old with relapsed B-cell ALL. He's day +7 from his CAR T-cell therapy, and he comes to clinic febrile, tachycardic, low blood pressure, and he looks like he's oxygenating okay. So technically this is grade 2 CRS because he has a fever, he has low blood pressure, And basically what we would do, because he's at risk for infection, we're going to get blood cultures because we can't necessarily rule out that it's CRS and not sepsis. We give antibiotics to rule out sepsis in the meantime, give IV fluids to support his blood pressure, and then we admit him for further monitoring. And that is that.